Hi, the last talk for this case will cover Hirschsprung disease and factitious diarrhea due to laxative abuse. Now you may be wondering what connects these two topics. Why is Dr. Poole discussing them together? Well, I have to confess that they don't really belong together at all. They are just two topics that I need to cover for the sake of completeness, and each of them have their own interesting points, and that's really the stout and skinny of it. For one thing, these two different entities are seen in totally different patient populations. Hirschsprung disease is a disease of infancy and early childhood, whereas laxative abuse is seen in middle-aged to older adults, usually women. Hirschsprung disease is usually suspected clinically. One sign is obstruction, and this can be manifested by bilious emesis, which means vomiting bile-containing material, abdominal distension, or failure to pass stool or meconium within 48 hours after birth. Physical exam may also show abdominal distension, a tight anal sphincter, and the squirt sign on digital rectal exam. The squirt sign is an explosive expulsion of gas and stool after digital rectal examination, and is also called the blast sign. So if you can get a mental picture of that. Now this may relieve the obstruction temporarily, but it always recurs. Affected infants may also present initially with enterocolitis, and this is a potentially life-threatening illness in which patients have a sepsis-like picture with fever, vomiting, diarrhea, and abdominal distension, which can progress to toxic megacolon. Hirschsprung disease is the eponym for congenital aganglionic megacolon, and I like this name better because it precisely describes the pathology of the disease. So I'm going to break this down just by focusing on each of these words and what they mean. So congenital. Hirschsprung disease is actually a fairly common entity present in 1 in 5,000 live births, and there is an excess of males with Hirschsprung disease. At least 12 different genetic mutations have been identified in patients with Hirschsprung disease. The predominant gene affected is the RET proto-oncogene, with mutations in this gene causing a loss of function. It's also associated with a number of different chromosomal abnormalities. The details you can fill in later in your pediatrics rotation or even in residency, but note for right now that it has a particular association with Down syndrome. Aganglionic. What does that mean? This is another nice connection with what you're learning in anatomy and histology. Recall that the enteric neuronal plexus develops from the migration of neural crest cells craniocaudally into the bowel wall. The most current theory of the cause of Hirschsprung disease is that there's a failure in the migration of neuroblasts from the neural crest to the distal end of the colon, which would represent the farthest distance that these neuroblasts would have to travel from the neural crest to the distal end of the colon. Failure of these cells to reach the distal colon then leaves that segment aganglionic and therefore non-functional, which results in the clinical entity we call Hirschsprung disease. The diagnosis is established by the absence of ganglion cells in the affected segment, and this is usually diagnosed by rectal biopsy. Usually we need some special stains just to confirm the absence of ganglion cells, although you can readily recognize ganglion cells on routine H&E stains. There's supportive features that aid in the diagnosis, which includes the presence of hypertrophic nerve fibers. So I'll do a quick little histology review. Remember that there are two plexes in the bowel wall. There's the submucosal plexus, also known by the eponym Meissner, And the blue arrow points to a small nerve, and there's some ganglion cells in there. The plexus is actually easier seen in the myenteric plexus, which is located between the inner and outer muscularis propria layers, and this is called the Auerbach plexus. And these are usually larger and easier to see just because the nerves supplying the muscular wall by necessity are larger. And that's what's indicated by the blue circle. When you look at higher power, you can identify the small nerves running in these plexes, and then the yellow arrow is pointing at a ganglion cell. And these have a very characteristic appearance. They're large cells with abundant eosinophilic cytoplasm and have a large nucleus with a prominent nucleolus. If you consider the nerve as an electrical cable, the ganglion cells are processing or signal relay stations in this process. So their absence makes the nerve carrying signals which can't be processed or distributed in order to enable their function. So finally, I get to an image of a rectal biopsy from a patient diagnosed with Hirschsprung disease, and the circles represent hypertrophied nerve fibers in the submucosal plexus. And remember, if you compare with the image of the submucosal plexus 2 slides ago, the nerves and ganglion cells are very small and kind of inconspicuous in the submucosal plexus, and the circles indicate how thick and ropey these nerves are. Also, there's no ganglion cells with these nerves, so that's the abnormality. And it's helpful to use special stains just to confirm that there are no ganglion cells in these areas. And the final word of our trifecta in Hirschsprung disease is megacolon. The rectum is always affected in Hirschsprung disease, but there is a wide variation in the length of additional colon that can be affected. Usually the sigmoid colon is affected, but actually the entire colon may be involved. The aganglionic segment usually appears contracted, while the normally innervated proximal region undergoes progressive dilation and becomes massively distended, and we call that megacolon. Some of the consequences of that can be mucosal inflammation and ulceration, as well as rupture, and this is simply due to the progressive thinning and stretching of the dilated segment. So this is a gross picture of a segment of proximal rectum and sigmoid colon, in which the segment that's indicated by the box appears smaller in diameter compared to the proximal colon that's uninvolved to the left. And it's not the greatest example of megacolon, but you get the idea of this contracted aganglionic segment. The image from Robbins shows this a little bit more dramatically. This is actually an intraoperative photo on the right, and I circled the megacolon segment and then drew arrows to compare the dilated segment with the blue arrow with the diameter of the aganglionic segment by the red arrows. So that should give you a good idea of Hirschsprung disease, or if you can remember congenital aganglionic megacolon, then you pretty much have all the information you need to deduce other features of the disease and build on some of the clinical findings and epidemiology and pathophysiology of the disease. So I'll completely switch gears now and discuss factitious diarrhea, which is due to laxative abuse. Factitious diarrhea is a self-induced true increase in stool frequency and volume, or sometimes is due to the creation of an apparent increase in stool volume by the addition of various substances to the stool. Early diagnosis of factitious diarrhea can prevent patient self-harm as well as iatrogenic complications that arise from unnecessary tests and treatment. So that's why it's important to always think of this in the back of your mind if a patient presents with chronic watery diarrhea with no apparent explanation. Patients with factitious diarrhea often present with a history of frequent large volume watery diarrhea. Surreptitious laxative abuse is the most frequent cause, and why I discuss it here. In patients with factitious diarrhea due to laxatives, diarrhea is often associated with cramping abdominal pain due to an increase in the fluid content of the stool and enhanced gastrointestinal motility. Hypokalemia, or decreased serum potassium, is frequently present due to losses in the diarrheal fluid. Finally, chronic diarrhea caused by laxative abuse often results in metabolic alkalosis. So, even though this is a self-inflicted thing, it causes a variety of pathological derangements. The diagnosis is a diagnosis of exclusion. It can be suspected on clinical grounds. Laxative screening on a stool specimen can be performed for certain types of laxatives, such as diphenolic and polyethylene glycol containing laxatives, but it cannot reliably detect anthraquinones such as Senna or Cascara, and there's assays that don't exist for other types of laxatives, so laboratory screening is of limited value. Now, usually laxative abuse is not associated with specific pathological findings except for one case, and this is called melanosis coli. And as the name suggests, it means black colon. Now, this is associated with the use of anthraquinone-containing laxatives. You can see melanosis coli in other chronic colitides, although it's most often associated with this type of laxative abuse. Notably, it's not associated with the use of osmotic type or diphenolic laxatives, so it's not specific to laxative abuse in general, but is associated with the use of this particular type of laxative class. Now, the morphology is pretty dramatic. By endoscopy, there's dark brown discoloration of the colon with a speckly pattern due to the lymphoid follicles which shine through the mucosa as pale patches or dots. Grossly, there's diffuse dark brown to black discoloration of the mucosa, and microscopically, the lamina propria is packed with numerous pigment-containing macrophages, and this pigment is lipofuscin. So this is the characteristic appearance that one would see by endoscopy. Sometimes the colon is removed because eventually it becomes non-functional, and that's kind of the loose connection with Hirschsprung disease. Because of the chronic laxative abuse, the colon just loses its normal peristaltic activity, and the mucosa has this diffuse brown to black appearance. And this is the very characteristic microscopic appearance. The lamina propria contains numerous macrophages which contain this finely granular golden brown to brown pigment, which is lipofuscin, a breakdown cellular product. All right, let's recap. What did I learn? I learned about congenital aganglionic megacolon, known by the eponymic name Hirschsprung disease. This can be suspected clinically by a failure to pass meconium or stool or abdominal distension in infants and young children. The pathology is notable for what we don't find, that is ganglion cells in the submucosal and myenteric plexes of the affected segment. The rectum is always involved, and with variable lengths of involved colon proximally, and it's due to a number of different mutations, most commonly affecting the RET proto-oncogene. And finally, learned about the exciting topic of factitious diarrhea, in which patients have a chronic watery diarrhea of unknown etiology. It's a diagnosis of exclusion, typically due to laxative abuse. A specific form of this that can be recognized pathologically is called melanosis coli, and this is specifically associated with anthraquinone-containing laxatives. So that is the conclusion of this topic of Hirschsprung disease and factitious diarrhea due to laxative abuse. Hope you found it informative.